And we're live.
Good afternoon and welcome back to everyone for this first OC3PR after a much needed summer break. I do hope that everyone was able to get some time away, as we know it's been a long stretch, but sometimes that's easier said than done. So here we are, about 18 months after the start of the pandemic, and like a bad rash that won't go away, we again are facing an increase in COVID numbers and ongoing issues related to COVID. As we continue to hear about the very concerning impact it has had on our staff, our friends and colleagues, as we debate the vaccine passport and implications of mandatory vaccination for staff, we thought it would be important to reflect on what was done to address the pandemic so far. A lot has happened, to say the least, and as we will hear, there was a significant amount of innovation, accommodation, and a lot of individuals going above and beyond what was to be expected. It is something we should recognize and be thankful for. As many of you are aware, our Ontario Critical Care Clinical Practice Rounds, OC3PR for short, is our ongoing webinar series sponsored by Critical Care Services Ontario to help address concerns expressed by various health professionals, learning and sharing of best practices to help better align Ontario's critical care teams in the care they provide for very ill patients. The format of OC3PR will be similar, including an opportunity to submit questions, which today will be fielded by Dr. Josée Thériault and Mike Sullivan. This webinar, along with previous sessions, are available at both the CCSO website and their YouTube channel. As before, please do your best to keep yourself muted. Please again, take the time to fill out the survey at the end of today's webinar, as your feedback is greatly appreciated and will help us plan future webinars. Continue to look for CCSO website and consider following them on YouTube and Twitter. The unprecedented demand that COVID has placed on ICUs throughout the world was also seen in our province. As should be expected, the distribution of patients was unbalanced, with certain centers pushed beyond capacity. To ensure care could be provided to all patients, our system went to great lengths to share the burden and move patients only when needed, but to move patients nonetheless when the need was present. What enabled us to do this vital rebalancing was the work of two crucial Ontario organizations, CritiCall Ontario and Ornge. As we will hear, they allowed for movement of patients, most of them critically ill, that we had never witnessed before. New systems, new processes, and many people working to make it successful. It is thus a wonderful way to start this year's OC3PR to hear and hopefully recognize what was done. To tell us what happened, we are fortunate to have with us two individuals who were instrumental in making things successful. The first is Miss Isabel Hayward. She's the Executive Director of CritiCall Ontario. It's hard to believe that she has over 30 years experience in healthcare, as she looks too young for that, with over 20 years in various leadership roles. Prior to joining CritiCall Ontario in 2016, Isabel was the Director of Acute Medicine, Critical Care and Emergency at Hamilton Health Sciences. She's a graduate of McMaster's University Bachelor of Science Nursing degree program and holds a Master of Health Science from the University of Toronto. Her passion is developing people and teams to help them achieve their full potential. Presenting with Isabel will be Dr. Michael Lewell. Mike completed his medical school and residency in emergency medicine at Western University in London, Ontario, where he now practices today as an emergency room physician at London Health Science Centre. Mike is an associate professor of medicine at Western University. He too has over 2 decades of experience as a medical director with land and air-based transport systems. That I can believe. He was the chair for the Ontario-based hospital Group Provincial Medical Advisory Committee to the Ministry of Health. He's been a transport medicine physician with Ornge since 2007 and presently serves as the acute Associate Medical Officer of the Medical Advisory Committee. Our objectives today include hearing about the activities undertaken by CritiCall and Ornge during the pandemic, including what worked well and what challenges emerge. We will hear important lessons learned, including potential strategies for the future. Isabel Michael, thank you for taking the time to come speak with us today. I'll pass it over to you.
Thank you. Thank you so much, Dave, for the introduction. And I want to thank the CCSO and OC3PR for inviting Mike and I on behalf of our teams who did the magic. And we are really excited to share some of our learnings. And as you mentioned, the objectives, as well as the lessons learned and what might be applicable to non-pandemic times, as well as improving, which is, what we're all hopeful for, is that from this, there will be improvements and successes that we learn from. So we'll go to the next slide, please. So what you're looking at here is the 3 waves. We are in wave 4, as Dave mentioned. We're going to be speaking to the learnings from the first 3 to date. And the waves speak for themselves in so many ways, because what was required in this pandemic was the need to be nimble and to adjust our processes and the requirements, because each wave had different perspectives and different needs to be able to manage and ensure that there was safety across the system and sharing of the patients. So what we're going to speak about are some of the changes. And with the CCIS that you see in wave 1, it is important to talk about our partners with CCSO. They are the strategists for critical care services in the province. And as this evolved, the need to work collaboratively with them and looking at what fields should be added to CCIS, which is our critical care information system that a lot of you are familiar with, and the need to have the right fields, the right way to monitor and have the data that was so key for the requirements throughout the waves, and the modeling and that led to some of the discussions at the various tables. We did have a lot of changes within our call center, as you can appreciate, with the different regions, all very different in some of the things they needed to put in place, their processes, and leaders. Our regional leads were key in keeping the communication and working with us. And our call center had to be reacting to requests, sometimes on a daily basis, to change some of the processes and being able to still do the regular work while learning new processes that were required for success. In our wave 2, our PHRS Total Hospital Occupancy Board was being implemented to become automated. And the reason this is here is the importance of also looking at what projects and perspectives that both Ornge and CritiCall were undertaking, and the decisions made were important, because they did lead to having the right platforms to be able to utilize as key processes for the pandemic. In wave 3, we did work also in wave 2 with IMS Transport and GTA. They were key, which we're going to talk about later. But also in wave 3, that was evolved further. And with their processes, we were able to then work at launching the Ontario Patient Transport System that we'll discuss. And we also were involved in collaboration with many in the province in facilitating Manitoba COVID patients to and from the province at a time when they were challenged, and we were able to be supportive and assist in their time as well. We will speak to some of these things later on, but what you're looking at in the graph is the CRCI, or COVID-related critical illness in the ICUs during the 3 waves, and in the importance of understanding the implications that occurred. So I'm going to pass it on to Mike for the perspective of Ornge.
Thank you very much, Isabel. And if we could advance the slide, that'd be great. So on this slide, what we're seeing is mirroring the second and third waves. And so I thought it'd be helpful to look at, in a similar process, what Ornge was involved with in each particular wave. So in wave 1, we were more operationally focused, looking at, first of all, having a seat at the command table, or command center, which is actually one of the best moves we did, to sort of be integrated within the critical care community, sitting with our partners, CritiCall, as well as CCSO and Ontario Health, and the ministry, to actually be able to identify what resources are required. Operationally, we developed new COVID-specific policies and procedures for our crews. We clarified the scope of practice, that what was safe and what was not, in terms of high-flow nasal cannula, as well as non-invasive ventilation in fixed-wing and rotor-wing aircraft, and developed further operational clinical guidelines for our crews. And then we worked with hospital partners to be able to identify what specific IPAC practices were variable and how we could streamline that for better access and flow for our transport crews coming in and out of hospitals. In wave 2, as the volumes increased, We took on a dual role of leading the Northern Ontario immunization program called Operation Remote Immunity. And that was a challenge for us because it strained our crews as well, because it's the same people doing ORI as it was doing the transports. We partnered with land ambulance paramedic services to be able to help identify patients that were less critically ill and didn't require critical care medicine during transport. And they helped to provide a lot of the transports for some of the less acute people. And finally, we also collaborated with CritiCall to develop a new novel dispatch strategy. We had our transport physicians reviewing every transport to make sure they were safe for transport and we could assign the appropriate asset. And that led to novel designations of the different transports from IMS acute to IMS rescue, depending on the capacity challenges identified at each hospital. We expanded our high-flow nasal cannula to fixed wing, and we also developed a prone ventilation strategy and training for our crews, which enabled us to move the sickest of the sick to centers such as UHN for ECMO. And finally, during wave 3, where the volumes were so large, we had moment-by-moment contact with all stakeholders at the command center to identify which hospitals were facing a loss of functional integrity, and directed our crews that way at 16 hours a day by physician-led dispatch in our dispatch center. And I would be remiss if I didn't identify how our staff rose to the occasion by having, supported by the Ministry of Health with generous funding, we expanded our hours. We borrowed every available transport unit from our land paramedic services teams, and we had a provincial-wide call-out for staff, and they responded with all kinds of overtime to be able to meet the transport need. And finally, we provided, along with CritiCall and the command center, operational advice to our partners in Manitoba who are facing a similar crisis in wave 3. On the next slide, we'd be happy to talk about what worked well through all of this. And I think one of the most important things is the message of collaboration, the sense of community we had with regard to the critical care community and being at the table. That really made a difference. Trusting each other in terms of our various areas of expertise through CCSO, through CritiCall, through Ontario Health, and having a clear command structure and trust that everyone else is doing the right thing for the patient on a singular focus of getting transports and patients to the destinations they needed. It was inspiring to see our staff supporting every available shift, and it was incredible how we were able to leverage existing technologies into operational plans and actually have things roll out that way. And we had tireless support without a lot of red tape from our partners at Ontario Health as well as the Ministry of Health to fund all of these. The fact we were able to scale and adapt to the different processes really was part of the keys to success.
Thank you, Mike. And the next slide, please. Again, throughout this, it is, again, about collaboration, partnerships, but our teams were amazing through the process during this, and we need to keep saying that because it's so important. This slide here, I mentioned already before about the changes. It is important because we have to learn from what was needed and what do we then proceed in improving. So what you're looking at is the CCIS Critical Care Information System updates that I was referring to, and when they were put in place, so March 19th, fairly early on. And the system was actually developed post-SARS, the CCIS system, and the pandemic itself showed the ongoing importance of this, of the richness of the data that's in the system, and how important it is for the development of the different waves and the learnings. But it also showed some challenges, which is the information is not in real time. It is actually, a day prior, which created some difficulties as people were trying to look at what was the reality they were facing that morning and what the numbers may be showing. But again, the work with Critical Care Services Ontario in looking at what do we know now, what should be reflected in this tool, so that we can absolutely capture the most up-to-date information of what we knew. And as we learned through the different waves, there was changes that were made to reflect that. So in the ability to be up-to-date with those processes. And then on March 30th, the importance of the pandemic incremental units. They were added to CCIS to support the ongoing enlargement of the footprints that were required in many centers as they were seeing the modeling, as they were seeing what might be coming, and definitely the hotspots that were already requiring to go beyond some of their initial areas that they would normally go to. So those incremental units were added to CCIS as well to assist in making sure we didn't lose that data and that we did justice to the amount of work and the acuity of what everybody was managing. So we'll go to the next slide, please. This slide is about our critical care dashboard that was initially put in place. There is a critical care command table that was very key to the management of this pandemic, with key leaders, regional leaders in the province at this table. And data was so important, and this became one of the items that we need to learn from and be able to be proactive with post-pandemic. Initially, because we leveraged CritiCall Ontario's Core BI, we were able to be quick and at putting the dashboard together. But as we looked at what was needed and what needed to be reported further, CCSO became the point of truth for that command table and for the province with their daily reports that were key, that all of you would have seen and been able to look at and use them at your tables for the discussions and the processes that came forward. So I think we'll go to the next slide.
So what this slide tries to show is a schematic of exactly how the system worked when booking a transport, because this was all new for many centers that were actually typically receiving centers or now actually sending centers. And so therefore, we thought it'd be helpful to have a single point of contact to improve efficiency, such that CritiCall was called. They would identify, and this is new work for CritiCall and required a significant process change, because they would field all the calls under the IMS orders, and then if medical care was not required and the patient could be moved by private transport, that was arranged separately. If a patient required ongoing medical care, the call would then come to the Emergency Operations Center at Ornge, whereupon our transport physician would review everyone in real time, call each sending and identify which patients required which resources, and could identify which patients required critical care resources, at which point it was an Ornge transport, and which patients could be moved safely by land EMS. Because we were having so many different transports with such variable levels of care required, safety was imperative. So we had 16-hour-a-day transport physician coverage in our Emergency Operations Center, sponsored by the Ministry of Health, as part of our business plan, to be able to account for which patients were appropriate for land paramedic services and which patients were appropriate for critical care. And this sort of is the flow of how we actually managed to move the patients.
And what was added here, that's important to note, is went outside of what normally Ornge and CritiCall manage: urgent, emergent, life or limb. And we were also now assisting with acute and at times ALC in the flow and the processing. And again, this was with starting off with the GTA table in Toronto and the transportation and the processes that they initiated. But it was really important that it was picking up something different, but the importance of capturing and being the point of truth for the numbers and where the patients needed to go, so that there was one area that was collecting that information. That again was really key for this process. Absolutely. So we'll go to the next slide, please. So this slide again is as we progressed in the waves and the need for, again, more real time. As people would say, we don't have transparency to where the patients are. We don't know if they've left, when are they due to arrive, if patients were changed because their acuity changed, and trying to have a better way to capture that flow and how could we improve that for all of the people who were involved in making sure safety was the number one process in all of this. So this is just showing the flow of what we worked on, and this project leveraged the existing technology from CritiCall Ontario's repatriation tool and Ornge's PTAC system, and that enabled the hospitals to align the identified patients in their IMS directives with the numbers and the PTAC number that was designated from Ornge to be able to really track the patients, have a unique identifier for these patients. And it was as close to real time as it could be. We went from having no visibility to having 15-minute updates of where the patients were. And this occurred in the third wave. And it was a rapid cycle project led by Ontario Health. So again, we had a new partner to work with, which was great. And it involved multiple partners with obviously CritiCall and Ornge, but also the CACs, the paramedic chiefs, and the hospitals, the flow coordinators. It was really amazing to have so many people that were working straight out many hours to try and do the right thing. And that was what held it all together, was everyone coming to the table with one goal and making sure that we had a better way to monitor and be able to assist with the hot spots and look at the patient movement and be able to monitor where they were at in their journey. So if we can go to the next slide. So this was the development of the Ontario Patient Transfer System. You can appreciate 22 CACs that were involved, as well as looking at the hospitals that were all involved in inputting the information, inputting acute ALC, process for ALC, and having critical care and the directives from critical care and the directives for acute all coming through one place, and being able to close your eyes and hope that when you open them, it all worked out. So a lot of people in the background making this work within 2 weeks, and this is a process that would normally have taken a very long time to put together. So it speaks to the removal of barriers, the removal of red tape, the removal of many of the things that can slow us down. And what you're seeing here, we've removed PHI from here, for obvious reasons, but you can see that you'd be able to look at pre-booked all the way through arrival at receiving, and you would know the directive, you would know which patients were coming from which facility, which were coming to you, and the ability to then see through this tool where they were at in their journey was extremely helpful in the third wave of the pandemic. So we'll go to the next slide, please.
So as you can imagine, with all that volume of transport and as all the different changes in technology, there were numerous challenges we all confronted, every organization as part of the command center. There was our normal spheres of influence by which we operated, and there is differences in terms of people's normal comfort levels working together. And that sense of community and the message of collaboration is one of the take-home messages that really what could have initially been a challenge, one actually being one of the key lessons learned and a really great accomplishment out of this, one of the lasting legacies. From an operational perspective as Ornge, we actually struggle with maintaining our dual role with providing ongoing emergency transports and coverage for the traditional emergencies that are non-COVID related, at the same time trying to support the massive movement of patients as required during the third wave. So the sheer volume of transport and the work-life balance that was there and the exhaustion of our staff was one of the key challenges. We also learned some things about our own fleet. We learned that our fixed wing fleet is limited in terms of its access to different areas. And also, as we tried to expand to Manitoba, our ability to support them was actually limited just based on the operational performance envelope and the distances that were required. We learned a lot about different operational things such as ambulances and oxygen supplies and radius, which we can actually transport with available oxygen on our rotor fixed and land trucks. And not every ambulance is built the same. And we also learned a lot about staff burnout and work-life balances and our challenges to communicate all together. Alignment was also one of the challenges we had with regard to media relations and the messages, and also management and control of the data to make sure we're always providing the same information, because we noticed that a lot of the media reports were coming to us, various agencies, and we wanted to be aligned in our message. And that was a key challenge we had, and I think we rose to the occasion in that way as well. I think, Isabel, your organization had some other challenges that were unique to yours as well.
I think you've said a lot of them, they're very similar, but as well as trying to do the regular business in a world that people were learning different ways to respond quicker, and it became sometimes difficult to be able to ensure that we were still having the right point of contact and that we were having the right safety measures in place. And sometimes we were chasing some of the processes because people were so great at wanting to, roll up their sleeves and be part of the solution. And at times we would then have to go back and try to figure out how do we reconcile some of these numbers. And it was all for good reasons, but that did become one of the challenges. And again, it is a complicated system to navigate. When you think about the different regions, they all have different challenges that they're dealing with. Not all are the same, and you can't fit the same solutions to each region. And I think that was something that was a challenge, but also an opportunity for us as we move forward to ensure we don't lose sight of those things as well. So we'll go to the next slide.
So I think some of the key lessons we've alluded to in some of the challenges, and that is that leadership and coordination and having that sense of community at the table with everyone trusting each other is essential for alignment, and providing those key messages in one single point of contact backed by one single source of data as the truth is essential for alignment. I believe that having CritiCall and transports literally at the table and be able to speak frankly about what the operational challenges and limitations are is essential. We also learned that duplication of efforts is not productive, certainly, and a singular laser focus on the mission at hand is essential. There are certain gaps in the system that we've addressed that we need to be able to identify for the future. And one of those is that the ability to remove barriers when time is of the essence. And I would like to believe that I'm proud to say that our partners at Ontario Health and Ministry of Health really made that happen, approving business plans overnight, literally, to be able to get the necessary resources in place. And one thing we must remain vigilant is about that this is going to happen again. There will be other medical emergencies. We are entering the fourth wave. There will be another pandemic. All of these things are essential to maintain the vigilance that's required to be able to be prepared for the next challenge. And specifically as the distance from wave 3 fades and our memories fade, it's essential to keep this at the top of the forefront when we look at other different developments of technology, collaboration, permanent senses of community amongst the critical care community to be able to be ready to respond as needed.
Thank you. And I think one thing I didn't mention, which is important as well, is, our researchers that were key as part of this pandemic and trying to make sure that they had the information to be able to do the research to help the different tables and learn from this. The system was hard to navigate for some of the requests. And I think that this is also something that we need to not lose sight of and be able to improve provincially from this. So thank you. We'll go to the next slide. So looking at what did we learn and what does that mean for future state? And this is the importance of building the future together with our key partners. And that is the ongoing theme here. And when we think about some of the things on this slide, Critical Care Services Ontario, Ornge, and CritiCall always work together. There are key processes that cannot go without the three collaborating together, but there are other entities that are important as well. And as we move this forward, so looking at some of the things that we learned and where are we going, CCIS, as we talked about, the Critical Care Information System, and it's shown its value over and over. But what was important was that it wasn't in real time, it did become a clear source that needed to be managed going forward. So we did put forward a request and thanking the Ministry of Health for agreeing to fund CCIS modernization, which will allow for automation as real time as possible and working through the hospital systems that they have in place and picking the fields from to modernize in real time the system. And so we're working through that with Critical Care Services Ontario. It's a lot of work, as you can appreciate, and key to have our frontline participate, the users participate, because it has to be meaningful and show improvement in assisting, decreasing the amount of work that they had to do. There was a lot of work, a lot of paper during the different pandemic phases, and we heard that loud and clear. And so this is one that we hope will be a great improvement. Secondly, our repatriation tool. So developing the repatriation tool along with one number to call phase 2, which will include pediatric and neonatal transportation. And this tool was used in different areas during the pandemic, which also allowed us to see the potential. Champlain's an example of how they utilized the tool to help flow their patients, and we learned from their utilization as we worked with them. And this tool has a lot of potential as well. It was the backdrop for the Ontario Patient Transfer System, which we're now working with further integration with Ornge, with the Flight Vector and PTAC. Both of our teams have been working on this already quite a lot because we see the value of it. It'll get rid of duplication and then it'll become a better system overall for everyone. Looking at data integration, as Mike mentioned and we talked about, and the importance of CCSO, CritiCall, and Ornge, we all had different pieces of data that we were responsible for, and being sure that we were collaborating and that it did make sense and that it did speak to the story that and the transparency and the point of truth. So that needs to continue. We're looking at Life for Limb is here only because there was an agreement to pause. And again, Critical Care Services Ontario leads the policy, and it's extremely important for the province. We did pause it during the time of COVID, and so it's here for let's review where we're at with Life for Limb and where would it go. And that's going to be a conversation with CCSO and partners and seeing what the next step would be, as well as the search process. It was streamlined to be quicker process because we utilized our regional leads as our resource for what was happening and what they were able to take and not take, and having those conversations. And so again, we have to learn from that, and should that look different, and we're looking for our partners in CCSO for that important conversation. New modes of communication was something that was on our work plan, as well as Ornge's. So it was great when we got together to have this conversation about our learnings and our processes that we both talked about, using the phone system and what that means. And we saw this clearly through the pandemic, where our physician leads were utilizing encrypted ways to have these real-time conversations and saying, who's in trouble and who do we need to decompress and how many and where should they go. And it showed us indeed that we need to change how we communicate, how we operate, and being able to leverage different ways to get the information to our key stakeholders, our physicians, to be able to have a different way of managing what we do every day. That's extremely important. We don't want to lose sight of that. So these are some of the key points that we wanted to bring forward. I don't know, Mike, if there was anything you wanted to add.
No, I believe that's excellent. That's a great list of where we'd like to be. And I think that I believe that's the end of our presentation, and we're ready to take some questions.
Only to Mike.
Only to Mike, eh? Oh, well, that's fantastic, guys. When you present all of that, I think there's going to be a lot of lasting legacies, and it's almost, how are we going to do a debrief on that? Like I say that almost in that we not only need to recognize what we did, but I think a lot of good will come out of this. And it's almost, where should we invest a little bit more? So I'll start with you, Isabel, since you asked me to start with Mike. What do you think will be the biggest legacy for CritiCall and your biggest challenge going forward? And then I'll ask the same of Mike.
So I would say the biggest legacy, I have two. I'm gonna go outside of one and say two. Is again with CCSO and the work with the CCIS automation. This tool is important, but we have to make it more seamless and real time as possible, and that will help even further with what the needs might be as we move to wave 4 and forward to another pandemic. But the other one really is the flow of patients in the province, and what we saw as the need, not only with the critical level patients, but if you don't have flow downstream and you don't have the ability to visibly see that and have a process to be able to capture it and assist in the movement of these patients, it does still affect overall the critical care, the high level beds that are so required in this. And so having the ability to increase the work that we were doing with the repatriation tool with flow, we like to call it flow management, and increasing it to all patients, including ALC. We think that will be a legacy that will make a big difference in the province as well. And what was the second part? The challenge? The challenge is going back to the way we're supposed to work. It's a lot of fun to work outside of the box, and having everybody with a common focus, and everyone trying to say, what can we do and how can we work together? And there are things that have to be done a certain way, and there's processes, and they're there for a good reason. But it is hard sometimes to be in both of those lanes, doing the regular, going back to the regular processes that we were so used to, but yet needing to make sure we don't lose sight of what it can be, and having the direction, the right projects to move it to the next stage of what has to happen. That's
great. Thanks, Isabel. And I do agree with you that patient flow as opposed to repatriation will certainly be one of those future endeavors that is here to stay and how we improve it. Mike, any thoughts from you on what you feel Ornge would say for that answer?
So I believe that one of the lasting legacies of this has been the familiarity that a lot of the critical care leads now have with how Ornge operates and what its capacity is and what its capabilities are or isn't. Prior to the pandemic, I think many of the critical care leaders in Ontario really didn't understand Ornge or how it worked or what we were capable of. So the lasting legacy is one of the fact that we're able to be integrated within the critical care community and seen as a valuable asset there and relied upon it in times of crisis. So I think that's the lasting legacy. And that's kudos to our staff and to the operational expertise they have and the specialized training that they have. I think one of the challenges we have is probably just that. It's the staffing itself and the specialized training, because what we learned is that we have some capacities that we were unable to meet. The challenge of getting large volume of patients from the north to the south or into your corridor, Dave, in Ottawa. We're unable to tap the resource that was available in Ottawa based on the limitations of our fleet. And as we look to the future about system augmentation and fleet augmentation with regard to new potential aircraft as the life cycles of various aircraft expire, and also the need to be able to have the dual roles that our paramedics provided on the emergency medical assistance team, EMAT team, as well as providing immunizations to the north, as well as maintaining emergency coverage, as well as maintaining the surge that was required for the pandemic transports. What we require is probably a recognition that we probably need to have more staff around to be able to mount that surge response that's required. And I think that HHR challenge is not unique to Ornge. That's probably, you're hearing that across your critical care community with your nurses. So absolutely, I think that's a common thing we all share.
That's great, Mike. We just asked you to turn your mic back on, Mike and Isabel, when you answer again. I'm going to go to Mike Sullivan, who is fielding the Q&A. And again, just a reminder to everyone to submit questions if you have any to Q&A, the various Q&As. Mike Sullivan.
Okay, thanks very much. Isabel and Mike, I wanted to just pick up on that, on the HHR challenge and really maybe kind of get at where, how your people are doing. As you commented, Isabel, it's like there's an exhilaration. Mike, you said the same thing of, kind of pushing through and doing all this kind of stuff. I think we've seen across, a number of our critical care community locations that people are challenged, they're tired, they're working hard. How are things where you are? And then, what are you doing about trying to help your people?
Isabel, do you want to start, or would you like me to go first? Or
you go ahead, Mike.
Well, I think that similar to the ICUs, we're seeing our staff is exhausted, and we also have limited staff, such that we're trying to get them their summer vacations and trying to have them their wellness and time to be able to recover from their Herculean efforts that was provided during Wave 3 as we brace for potential Wave 4 as well. So what are we trying to do to support our wellness? Well, we're trying to get them the time off they require. We're trying to support them through after action debriefs, as well as some of the resources we have from a wellness perspective at our organization. I think frank talk is important as well. We maintain our clinical town halls where we actually speak to our staff on a regular basis and debrief about what worked well and what didn't. So open communication to our senior leadership team is also essential to be able to vet some of the challenges we've learned and lessons we've learned. I think that's all we can do, unfortunately, at this point. And what we're trying to do is get back online with our continuous medical education to build that extra staff that, unfortunately, our CME activities and our training opportunities for advanced care paramedics trying to make it to critical care paramedics was put on hold as part of the pandemic as we had an all hands on deck approach. We're trying to reignite that to build us the redundancy we need for staffing models to be able to mount potential surge again if required for Wave 4.
Thank you. And I think what I would add to that is we're a little bit different in the sense that we're not in a hospital, we're not in a building where you see the patients. And so our challenge was also about, being in a building and not having that ability to go down a hallway and feel it and be part of the conversations. Our call center had to stay in place while everyone else was working from home. So you can appreciate that develops, a different kind of a dynamic as well. They were amazing. They came in every day. And some of our, again, our manager for the call center having to be always available because of the changes. So for us, it's also knowledge transfer. We have a small group, and so some had to be on all the time because they were the subject matter experts for some of the things that had to occur. And so for our learning as well was how do we start improving that a little bit and expanding some of that within our teams. And then here we are in September and having to look at our operating plan that we had put in place from before. Where are we at and how do we course correct that while trying to also make sure that we're not losing some of the things that we need to continue to keep our eye on. So it is more meetings as far as leadership getting together and looking at where we are and utilizing some of the forums we have for those conversations with our front line and making sure that they are acknowledged when they're off site and that they do get the same opportunities that are being offered in the areas where it's a bigger system as well.
Thanks, Isabel. Part of the reason I asked the question is because I know people are afraid, and we have had a great sense of kind of being together, but sometimes at these connection points. So hospitals and you and CritiCall and you and Ornge, and then Ornge and the hospitals. There's room there for people to when they're really distressed to be a bit afraid in their reactions. So I think it's important to understand that everybody has worked really hard, and that we're going to have to. One of the things that we're really going to have to work hard at is trying to help each other over this next little while. Dave, I got one other question that came in and said, can the numbers be shared? How many were moved? How many days? To how many hospitals? And I think I can answer that by saying that Andrew Baker, our commander, has a report that should be out fairly soon to go over all of those details. Not that we're trying to hold on to them. I just don't want to confuse things by saying some stuff right now. So yes, absolutely, that information is available and it will be shared out. Maybe I can pass it on to Josée and see if she's got some questions.
Excellent. Josée?
Thank you. Isabel, Michael, what a presentation. It is phenomenal to see the amount of work, and even having sat at the command center and being with you guys every time we met, it is still quite impressive to see with these slides the background work that went into it when you share it this way. So, and some of the stuff I wasn't even aware that was going on, in the background into those details. So kudos, this is phenomenal work. I'm curious, I think, all great questions, and I don't necessarily want to rehash things because, again, we feel the amount of work that has been put in from your staff from both organizations. And I was curious, just a question. I'm always very interested in the life or limb because of being in the North, because of our challenges. And you mentioned in your slide moving forward, and let's put aside the dollar signs at this point in time, but I'd like to hear your thoughts, both from a CritiCall perspective and from Ornge, your thoughts on the pre and what you think would be like the new life or limb or the bettered life or limb post pandemic. So I'd be interested to hear your thoughts. Thank you. Yeah, we can start with Isabel because your mic is off already.
Okay. I always like to talk, right? Actually, the reason that was on the slide was because we have a protocol for life or limb, and if there's not a response in a timely manner, and there's different processes that have to occur and letters go forward, and there was an acknowledgement with CCSO and us to look at, given all the pressures in the system and what everybody was dealing with, is this something that we should continue during that time, because we knew people had to juggle things differently, and we knew people were looking at ensuring safety for everyone. And so that's what the referral was about the processes that go behind the policy of life for limb, and not having to do the letters and the responses if there wasn't, the adherence to certain timelines of the response. And it really is, for Critical Care Services Ontario, for us to sit down and talk about what might that look like post-pandemic. But always an important conversation for sure, and learning from areas such as the North. Is there something there that we need to speak to our stakeholders? And I know CCSO does that regularly, but let's learn what might have come forward from the pandemic that could also be discussed as well.
Thank you.
From an Ornge perspective on the life for limb, I think we've learned from this, as well as the efficiencies we've gained through emerging critical processes with call taking and bed finding with our process of operations and actually transport. The efficiency we've learned through the life for limb process, we'd like to continue to carry that on for all transports to make it easier for the stakeholder that's looking to book a transport. If the efficiency is required at a time where patients were critically ill and there's high volume, we should maintain those same efficiencies during sort of peacetime activities as well, to make it easier for everyone. And lastly, as part of Ornge's operational ownership of the life for limb, it's our transport responsiveness and how quickly we can respond to an E1. And as part of this, we've actually added this to our organizational quality improvement plan, which is reviewed by our board of directors, and it's actually an external facing document, so it's actually reviewed by the public. So we're putting our money where our mouth is. We want to be able to try and improve our timeliness to the sickest of the sick moving forward, because that is, I think, one of our core missions and needs to be addressed as one of our key core focuses organizationally.
I just wanted to add, from hearing Mike's response, when we look at people declaring life for limb, and then is it really a life for limb or not? And that's not because people are trying to play the system. It's because people truly are trying to move a patient that they need some help with. So the importance of, that, like, just like stat, if you use stat, you're going to get it sooner. So life for limb, because CritiCall is involved with Ornge with a range of transportation, it really needs for us to look at the one number to call phase 2 that was paused because of the pandemic. That will include the urgent emergent patients. And as I said, the other pediatric neonatal assistance, and that might help even improve the life for limb, true life for limb, and the ability to do a better job with that. But also what can be an adjunct when there's areas that can't be reached, and how do we make sure when we look at virtual care and some of the abilities to assist those physicians who are in more rural areas, and are we doing all that we can? And that's work that with CCSO and CritiCall are on our operating plan as well, to make sure what do we need to add, how do we support better, and what do we want to make sure is in place.
I just want to say thank you again. And it's just phenomenal when you think about how we maintain the non-COVID support in the midst of, craziness, basically. So thank you again. Thank you. All right, I'll pass it on to Dave. Thank you.
That's great. I think you've touched on potential something for the future. Is the solutions are obviously going to be integrated. Life for limb was certainly a valuable change, and that came into Ontario several years back, and the idea wouldn't be, it's how do you tweak it to make it even a little bit better or more effective. And Isabel, you've touched on virtual care and some of the other aspects, which certainly we look forward to adopting in multiple areas, and I think it would be quite complementary. Just want to remind everyone, there is the survey link. If you could take the time, that would be certainly valuable. One of the final questions I have, and I'll see if there's any from Mike or Josée, but I was wondering if Isabel and Mike, you could comment on perhaps what was the most common misconception or mistake that you saw in your respective areas that perhaps people may not be as fully aware of, and where our listeners and viewers could perhaps do a little bit better going forward. We'll get Mike to start this time, and then we'll go to Isabel.
Thank you.
Well, I think that it's a reflection of the volume, to be perfectly frank. There's so many patients that require to be moved, and by potentially providers that oftentimes aren't previously in the field of selecting patients for transport. So the familiarity with the transport environment and the limitations that are imposed therein, I think may have been one of the unfamiliarities that some of the providers that were sending patients had. And I think that's where we leverage the expertise of the transport physicians in the emergency operations center, hand reviewing each one. And they were able to pick up some of the common pitfalls, such as potentially distance for transport on high flow oxygen that would actually exceed the operational envelope for the oxygen supply. We never want to run out of oxygen, especially on high flow nasal cannula, which essentially on high flow has a 60-minute transport radius, and that includes hallway time and parking lots and access and ingress through IPAC programs. So there's that. I would also think that the IPAC variability was a common challenge, but also sometimes very confusing, just because of we were forced to actually unload sometimes patients outside of critical care units, which led to some patient safety related events because of some misunderstandings as to what we were screened to be able to provide and where that transfer of care should happen. And last thing, I think that a sober second thought, sometimes looking at patients being selected for transport to community hospitals long distance, whose trajectory kind of looked like on a second evaluation that they'll be heading towards ECMO. So for instance, moving someone 250 kilometers prone away from when they're currently located 15 kilometers from an ECMO center to move into a community hospital 250 kilometers away from an ECMO center while prone on FiO201 and with few comorbidities and being 60 is probably not the ideal candidate selection to be able to move that way to avoid a secondary transport. So I think that was the also value that and I have to acknowledge the willingness and openness of those providers to have a conversation with their transport physicians and reevaluate that transport and find a different patient. And also recognizes that they were facing a loss of functional integrity based on capacity, but also challenged by consent and capacity issues as to patients refusing transport. So they needed to build capacity somehow, and this may have been their only patient they could select, and they get that. So, but that willingness to collaborate and be able to understand the challenges did lead to some decision making that changed. And I think those are some of the common mistakes that we're able to work and navigate through together.
You know, Mike, you said one, but I love your answer, Mike, because it has so many of the pieces that were difficult. I agree, but I just need to say something for everyone who are here. Maybe people weren't aware of our regional physician leads, our regional administrators, and how incredible every day the commitment and the impact, and also the unwavering ability to stay focused on the importance that patients come first. And it was a pleasure to be at these tables to see that and feel that. And I think that's something that people don't know about. You know, they might see our different leaders at different points in time in different meetings, but I don't think they understand that this wasn't a 1 hour thing. This was some days, 20-hour days, and all hours of the day. So I need to make that point, because that was also extremely important. But the one misconception is, you know, one individual person making a change, they might not think it impacts the system, and it does impact the system. When it's this big and there's so many moving parts and there's so many pieces that are important, that they're collaborated the same, and that we're measuring and ensuring the numbers are right. So even the question earlier about, can you give us an idea of numbers? That's not an easy answer, because there were some centrally measured, there were some measured outside of that. And so that in itself became an area that people were frustrated with, because what is the number? And we all want to give the number, but the number is dependent on where we're looking, on how it's being measured. So we had to keep going back to the point of truth is this area, and you have to go through if you want your numbers to be included, and you want the ability for people to see what you're involved with and being able to be part of those discussions. So I think those two things are really important: is the point of truth and making sure everybody has the ability to think differently and be encouraged to do what's right for their particular regions. But when it comes down to flowing and where the patient's going, who's capturing it, and that the data was very, very important.
That's great. And again, before I go to Mike Sullivan to close, I just want to echo some of the comments of others, the appreciation of both you, Isabel, and Mike. You guys were available. I can certainly attest to calling at some bad hours of the night, and you giving your cell phone numbers to allow us to communicate. And so certainly what you as leaders did, never mind your teams did, was above and beyond. And there was no hidden agenda. There's no hidden numbers. It's the truth. Like, as just for an example for the listeners, is the fact that when someone's COVID was resolved, some sites were saying they no longer had COVID, which I think we all agree they were in the ICU because of COVID. Wasn't because someone was trying to hide the numbers. It was just, how do you define it? And so, everyone was quite transparent, and available, and I have nothing but good things to say about CritiCall and nothing but good things to say about Ornge. So thank you both, and thank you to your teams. And finally, if there's a way we can help with your staff's morale, engagement, and things, I think all of us would be certainly willing to help and contribute in some fashion. So thank you both.
Thank you.
And Mike, I'll leave it with you to have the final word in the usual fashion.
Dave, you're terrific. I want to come back and pick up on what Josée talked about, just the the fact, I mean, for several of us here, we were at these tables every day, and I don't really think I understood the amount of work that was going on behind the scenes, particularly at CritiCall and at Ornge, to be able to pull this all together. And this was an enormously helpful way to be able to have a look at some of that. The theme throughout your presentation, if I was to pick out one word, was collaboration. And I think the necessity of having all of the parts of the system in a respectful and trusted engagement to be able to solve problems, was probably never more evident than here, but really runs through all of what we do. And so we are, as Dave said, really grateful for your work and grateful for your time here today to be able to let us see your work. The OC3PR will from time to time try and have some look-ins at some of these lessons learned as we've gone along. And we're gonna, because it's important to us directly, we're gonna wish you lots of good luck with your agenda for the future. Thanks very, very much. And thanks to all the people who came in today. We will be looking forward to topics on pediatric surge planning on October the 7th, and then on transport medicine and post-COVID ICU survivors and their outcomes sometime later in the fall. All right, have yourselves a great day, people. Thanks a lot.